Asante sana, the outgoing president, Dr. Mugisha, the incoming president, Dr. Alex, MAT Council, MAT zonal leaders, distinguished participants, ladies and gentlemen, good morning. I thank our Almighty God for granting us health and being here today. Before I start, may I have my team from NHIF to stand up wherever you are? Thank you very much. Mr. President, we are 50 this time, so you may sit. Thank you very much. So I will briefly talk about our role, basically UHI, Universal Health Insurance, in strategic alignment with Tanzania Vision 2050, HSSPV, and SDGs. So I will not dwell much in this slide, but basically we are talking about two basic objectives of universal health coverage. The first one is equity, and the second one is financial protection. And this is also in line with Sustainable Development Goal number 3, but specifically 3.8, achieving universal health coverage, when we talk about financial risk protection and access to safe, effective, and quality. When we talk about strategic alignment, broadly, yes, SDG, we talk about universal health insurance, but SDG number 3, I've mentioned about 3.8, but now narrowing down to Vision 2050, and then we have policies that, sectoral policies that, are going to implement it. So when we talk about strategic alignment with Vision 2050, we have UHI serves as a corner socio-economic pillar of Vision 2050, and it is within Vision Pillar 2, Section 4.2, Attribute number 4.22. And also, under the Health Social Sector Strategic Plan 5, is also under Section 2, Strategic Direction, subsection 5.4.8 on the financial resources. And again, I mentioned about the SDG number 3, but it is also a resolution of heads of state. Heads of state in 2008, they met, and in health, they had 9 areas of concentration, and one of the, area of focus, and one of them was universal health. But we cannot talk about universal health without talking about ILO minimum standards. So as a country, you are required to follow ILO minimums. We are members of ILO. So Convention 102 of 1952 pointed out minimum standards. So there are 9 benefits, but for the depending on the ability of a country to protect its nation, its people, at least you can start with 3, and 3 those are pensions, invalidity, old age, and survivors. But now, for the country like Tanzania, we have managed to go through almost now all 9. And the 7th one is about health. And the 9th one is about the family protection. So ILO, minimum standard, is also talking about health, but they will also have ILO recommendation. This is not a convention, it's a recommendation, which took place in 2012, recommendation 202, which has social protection flaws. Basically, when they talk about social protection flaws, are the flaws which prevent people to fall into poverty. And we know, Daktari has said, there's members, there are some families, they fall poor just to go to access surgery. So the aim is to prevent them. UHI, Universal Health Insurance, it has, in Tanzania, like other countries who are ILO members, we have 3 pillars. We have 3 pillars in pensions, but we also have 3 pillars in health. Pillar number one is non-contributory. For the one who are unable to contribute, they need to be protected. I think you have heard that NHIF has started registering indigent families, poor families, the families which were previously taken care by TASAF. So we have those ones who are unable to contribute. So these are social protection, social health insurance. And then, when the income increases, when you start getting income, you can start to contribute. But in Tanzania, we have a second pillar, which is called mandatory pillar. Whether you like it or not, once you are employed, you have to contribute to a social protection institution, whether it's pension or whether it's health. So it is mandatory. So for Tanzania, it is 6%, employees 3%, and employer 3%. So it is 3%. That is mandatory contributory. And then we have supplementary. Anybody can contribute, can buy a bundle, can buy more additional services. So Universal Health Insurance Act 2023 introduced mandatory insurance for all citizens, Section 5. I know Section 5 has not been operationalized as yet, because we have first to cover all indigent families. Because you cannot say it is mandatory for everybody, but there are some families which are able to contribute for the protection. And also initiate health systems reforms and set the country on a journey towards realization of universal health. This is all about WHO, what they talked about out of pocket, that we should be at least less than 15%. A high prepaid contribution with less dependence on external aid. Majority of Tanzanians, majority of people should be contributing, but also total health expenditure per capita of USD provision of essential benefit package is around 44. For our countries, they classify us as low income countries, has been ranging between 45, 43, 42, somewhere there. We are 44 US dollars. And here you will see our essential package, which is 150 Tanzania shillings for a household of 6 people. So you can see the difference between 25,000 shillings per annum per person vis-a-vis $44 per person. So we see Tanzania is 23, far away from 15, although we are better than our neighbors who are 24%. The Republic of Kenya and the Republic of Uganda is 37. So our strategic direction for UHI in Tanzania has 5 key elements. Element number 1 is equitable pooling, inclusive population, primary health care focused system, strategic purchasing, and provider payment. I'm told I've been given 30 minutes, so I'll try to go through them quickly. The first one, equitable pooling, is eliminating reliance of out-of-pocket, where we have UHI recognizing both public and private health insurances, eliminating out-of-pocket to avoid financial catastrophe and impoverishment. Also pooling resources to allow cross-subsidies. So I don't have that slide here, but you can see that an average household size as per the census, around 4.4, 4.5. When you look at average size as per TASAF is 3.2. Per NHIF standard package, average size, including the head and dependents, is around 3.8. But when you look at our bundles, Tarangire, Serengeti, Ngorongoro, Tanzanite, etc., is 1.2. It means somebody is full sick and go and to purchase a bundle. So there is no protection, there is no risk pooling there. On the right side, they are rather busy, but it's basically talking about our roles in the UHI and the sections that give us mandate in this area. So I won't spend much time into that. I'll go to the second point, which is equitable population coverage. As I've said, the 3 pillars. Pillar number 1, indigent families, that we have managed to start enrolling indigent families using TASAF identification, identified households, and so far we have registered 70%. The third one is primary healthcare focused system. You can see, according to actuarial evaluation for UHI, we have conducted actuarial evaluation, and it has indicated that 50% of the benefit payments goes to few tertiary level health facilities. As you can see, I'm not so sure if it is very clear to you, but you can see that regional referrals, you can see regional referrals, 2.6%, and you can also see proportion. Proportion is more than almost 25% goes between national, zone, and referral, which is quite a lot. And you can also see polyclinics are taking 18.9%. So if we want to have a proper working, functioning UHI, we need to strengthen healthcare at the primary level. Because even the package, you can see the price of package focused on the primary level. So what are your roles here? The roles of medical doctors with UHI, you have a number of roles. And I was so impressed by you, Daktari, today, when you talked about preventing surgeries. Madaktari, tuna shida kwenye moral hazard. Unajua kwenye health insurance kuna major risk, Adverse selection, ambayo iko kwa upande wa members, anakuja akiwa mgonjwa, that is adverse selection. Lakini kwa upande wa vituo ni moral hazard. Yani nimekuja labda ninajisikia kichwa kinaniuma, unaniandikia paka nikafanye CT scan, nikapime malaria, nikapime UTI, nikapime nini. Kwa hiyo you call it moral hazard, au kuniandikia dawa nyingi. Na hii inatokea sana mwenyekiti, president, outgoing na president incoming, we have kwa wazee. Jamani, mnawaandikia dawa nyingi sana zinakwenda kuwaua figo. Wengine unakuta dawa ni hiyo jina tofauti anatumia. Anatumia zote. Sasa zinakwenda kusumbua. Na unakumbuka daktari pale, profesa, alinitumia siku moja. Alinitumia prescription, tukaandikiwa picha ya madawa mengi. Tutawaua wazee wetu jamani. Alafu ndo akifariki tunamwandikia natural death. It's not fair. Tusaidieni jamani. And the third one is sustainability of the fund. Ambapo sasa kama mtatusaidia kwenye prevention, mkatusaidia kuwahi matibabu, na mkatusaidia kuaddress hiyo problem ya moral hazard, pia mtatusaidia kwenye sustainability ya fund. Lakini pia fund ikiwa sustainable, ina maana even coverage itaongezeka. Hata kile kitita mnacho kila siku mnalalamika, tutaweza kukiboresha. Lakini utaangalia sasa hivi trend ya malipo kwenye vituo vingi inakwenda tu ikiongezeka jamani, madaktari. Hakuna msimu ambao magonjwa kidogo yanapungua jamani. Yaani msimu kuanzia Januari to December kuna kuongezeka, Kwa hiyo pia ni eneo ambalo naomba sana tusaidiane. Another specific role in making UHI reality, this is a summary, only I have 3, 4, 5 areas. Again, it's just a summary of what I've said: delivery of primary and preventive care. Secondly, ensuring quality and safety. Third one is bridging public and private divide. And fourth one is the policy implementation and data collection. Keeping records is very important. And the fifth one is patient navigation and financial protection. So this is very important to all of us. So I really and humbly call for a very strong partnership. Yes, we have a partnership with you guys, and it's a very important partnership, but we need to travel together. We need to be together in this journey, improving quality of care, enhancing referral system. I think you remember my slide, my previous slide, where I indicated concentration area, that RRH being the leading. Please let us now trying to enforce or enhance our referral system. Promoting ethical, improving documentation. Wengi kwenye rejection madaktari na mnasema mnakatwa ni documentation. Yani tukishakuwa na inadequate documentation inafanya mfumo wenyewe kwanza unakata, na mtagombana sana na madaktari wetu wanaokuja maafisa wetu madaktari wakinapokuja kwenye vituo vyenu. Supporting strategic purchase, this is very important as well, and advocating for universal health insurance. With this one, we can also we can make sure we will ensure that we travel together in this. Universal health insurance is not an NHIF project. Universal health insurance is for all of us. So we are not just insuring lives, we are securing health as a macroeconomic asset of productivity, socio-economic future of Tanzanians. Together we can build health nation envisioned in Tanzania Vision 2050. Bima afya kwa wote, jiunge sasa. Asanteni sana kwa kunisikiliza.